Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you all to our webinar series entitled Medical and Public Health Considerations of COVID-19. Today we'll be having two presentations. The plenary presentation will be an update on testing, the new saliva test for COVID-19, and then we'll have a subsequent update from the front lines featuring two speakers from Lebanon. Next slide, please. I'd like to welcome our webinar series partners and thank them for helping to get out the word about our webinar series. I'd also like to welcome our newest member of our webinar series partners. That's the Association of Healthcare Emergency Preparedness Professionals. We greatly appreciate their participation. Next slide. This webinar, as well as all of our prior webinars, are recorded and are posted to the ACMT webinar page, which can be found at www.acmt.net/COVID-19 web. This webinar will be posted in approximately 48 hours, and all the registrants will receive an email with the link once it's posted. We also have been developing a series of webinar Q&As and FAQs, and this is also on our website. And any additional questions about our webinar series can be directed to us at webinars@acmt.net. Next slide. Following both presentations, at the end of the second presentation, there will be a general Q&A for both presentations. Please type your questions into the Q&A function during the webinar or into the chat box, and we'll get to as many of these questions as possible at the end of the presentation. Next slide. None of our speakers have any conflicts of interest to disclose. Next slide. I'd like to thank my co-moderator, Dr. Ziad Kazi. Dr. Kazi is a member of the Board of Directors of the American College of Medical Toxicology and also the president of the Middle East and North Africa Clinical Toxicology Association and associate professor of emergency medicine and medical toxicology at Emory University. Next slide. I'd like to say a special thank you to Dr. Robert Middleberg. Dr. Middleberg is the core director, laboratory director and senior vice president of quality assurance and regulatory affairs at NMS Labs. And Dr. Middleberg will be helping out with the Q&A toward the end of the presentation. Next slide. It's my pleasure to introduce our plenary speaker today, Dr. Ann Wiley. Dr. Wiley is Associate Research Scientist in Epidemiology of Microbial Diseases at the Yale School of Public Health in New Haven, Connecticut. And she has led the development of this novel test for COVID-19. It's really very exciting. It's cutting edge research, and we're really pleased that Dr. Wiley can address us today. Dr. Wiley.
For having me. Sorry. Do I have control? There we go. Okay. So indeed, thanks for having me this afternoon. I'm very pleased to be here to present our work that we've been doing, which has led to Saliva Direct, a simplified and flexible platform to enhance SARS-CoV-2 testing capacity. So this really started back in early March when a large group of just researchers, clinicians, a really great team from across the Yale Schools of Public Health, Medicine, Yale New Haven Hospital, banded together to form the Impact Biorepository. The idea of this is that we're going to form a study where we would receive samples from COVID-19 inpatients and build this biorepository of all sorts of different sample types, and to be able to sort of study SARS-CoV-2 and COVID-19 disease progression in the future. And through this is how we discovered the potential for saliva, and what eventually led us to the development of Saliva Direct. So Saliva Direct received its emergency use authorization on August 14th August 15th it was. And when we received it, it was described as the most unique EUA that the FDA has issued to date. What makes Saliva Direct very unique, first of all, is that this is a protocol. It's not a test kit. We're not making anything. We're not manufacturing anything. We're not distributing anything. What we have validated is the protocol for testing saliva that we're able to designate other high complexity CLIA labs to use Saliva Direct under our authorization. And if we make any updates to this protocol at all, these updates will get extended to all authorized labs as well. The goals behind that really drove the development of Saliva Direct were primarily to reduce testing costs, to try and make testing more accessible to communities everywhere, and therefore also increasing the numbers of tests available in people's communities, and also to help reduce the implementation time to use Saliva. So the idea that if we've done all the upfront, extensive validation work, now that we're able to share our method with other labs, they can just take the method themselves and start running Saliva Direct rather than having to go through such the extensive validation process that would be required otherwise. So indeed, so very early on, we quickly learned all the limitations with the nasopharyngeal swab, which I guess we had been aware of to some extent, but it was only when you had to start testing thousands and thousands of people of nasopharyngeal swabs and just realizing like how just all the factors involved with that really led to a lot of bottlenecks in the whole testing process. So first of all, of course, with the supply chain issues where, we quickly found that swab kits were becoming very scarce. We're having to order in our own tubes and making our own viral transport media. I mean, at one stage we were even researching 3D printing of swabs in case we couldn't get any. There's obviously risk to the healthcare workers who have to collect these swabs through both the discomfort that is caused to the patients when they're having these swabs, and the idea that this discomfort could lead them to sneezing or coughing onto the healthcare worker taking that swab. And in terms of research, I think we lost some opportunities for research because we didn't want to interfere at all with the clinical chains of this. So, these healthcare workers were first taking a swab for clinical diagnostic purposes, and then they'd need to take a second swab for us for research purposes. And you can imagine not many people were very thrilled about the idea of having a second swab, but neither were the healthcare workers, understandably, who were so incredibly busy and pressured during that time, but also having to go in to take a second swab was putting them at additional risk, which they'd already gone through with getting that first swab. So we very early on identified the limitations of swabs, and also that with all of these things, they were not going to be ideal for frequent repeat testing going forward. We were taking, however, all of our samples and processing them through RNA extraction and RT-PCR detection. Overall, this process is expensive, it's labor intensive, and again, we experienced, and as did labs everywhere, shortages in the reagents that were required for this. With our RT-PCR detection, we were targeting the N1 and N2 regions as issued by CDC, as well as the human RNase P gene as our sample quality control. So these were all having to be run in singleplex. So for every sample we processed, we had to do 3 qPCR reactions to test for the virus and human genes in there. So again, this was very labor intensive. So as we were receiving these samples and passing them through this RNA extraction and PCR testing, we were receiving obviously nasopharyngeal swabs, saliva samples. We received oropharyngeal swabs for a while until the swab shortage really sort of brought an end to that. We were collecting blood, urine samples, fecal samples, rectal swabs. So all of these samples were being used to build up the biorepository, and regardless of the sample type, we were testing them for SARS-CoV-2 RNA just so that we knew what was going on with these samples. And so as we were seeing sort of all of these problems with the nasopharyngeal swabs, and as we were watching the results coming through and how virus detection was performing in these different sample types, we started to realize that saliva was performing surprisingly well. We didn't want to get too excited too early on. It's clearly not your traditional diagnostic fluid, but it was performing very well for us. We were very keenly aware of all the issues that we were facing with swabs, so we decided just to keep an eye on it, and if there was potentially any potential for saliva as a sample type. So this is in the middle is a graph from our our paper, which finally just recently got published in New England Journal of Medicine. And it just shows that the viral loads that we found when processing swabs versus saliva, and that this was actually higher in saliva samples as compared to the nasopharyngeal swab. So, you know, combining all the issues that we knew with swabs and knowing that we were going to have options for frequent repeat testing going on in the future, and sort of wanting to move away from that limitation of swabs, this is where we really decided to explore saliva further and to continue to validate and optimize it as a sample type for SARS-CoV-2 detection. And with that, we developed Saliva Direct. So we had seen quite early on some preprints coming out where, you know, people were taking the viral transport media that their swabs were in and testing them almost directly in PCR. And, you know, so we also wondered, you know, would this be possible? So it really just started as setting up a PCR one day, and I just thought, let's put some saliva in there and see what happens. Results were mixed, but enough to be promising, and that there might actually be something in that. So we decided to pursue it further. So what we've done with Saliva Direct is we've removed that RNA extraction step. Instead, we take a saliva sample, which is very, very simply collected in a very plain, simple, wide mouth tube. We add some proteinase K, and then we vortex it very well. This addition of proteinase K just really helps to break down the sample, makes it easier to work with, probably can help start breaking down all those proteins, the mucus in the sample, and also the virus. We heat and activate the sample at 95 degrees for 5 minutes before putting it into RT-PCR. What we did is we actually dualplexed the PCR reaction. So we now test for N1 and RP in a single reaction. We've kept the RP in there as our sample quality control, just so that you know that, you know, if there was anything inhibitory in the sample, having a negative detection of RP would tell you that. But then that would also be good to highlight that, you know, if you're negative for RP, something's inhibited the process. So you actually really don't know the status of N1 or the viral presence in the sample either. So these are just to go into more detail, like our sort of thinking and theory behind the different steps, why we're doing what we're doing. And so the very first one is collecting that saliva sample in just a very simple wide mouth tube. What we found is that saliva is actually stable without any preservatives. So there's a lot of expensive saliva collection devices out there on the market, or that are part of tests. These tubes can range anywhere from about $7.50 up to $30 per tube, which, if you're thinking about it, if you're, you know, trying to do a mass testing program, that's, you know, really going to very quickly price out many sort of testing capabilities. So what we wanted to show was that, or what we found is that SARS-CoV-2 detection of N1 at least was remarkably stable just in a raw saliva sample, so without any fancy preservatives or buffers. So what we did for the EUA validation is we took a strongly positive saliva sample and we diluted it down to 12, 25, and 50 virus RNA copies per microliter. And then we incubated those samples at 4 degrees room temperature and 30 degrees for 7 days. And we actually saw a very stable detection of that N1 over that whole 7 days in those conditions. This really reinforced to us that no expensive collection device is required, and we can instead use just very cheap, simple laboratory plastics instead. What we also did, though, however, is we also just double checked this with our clinical samples that were coming in. So the graph on the left shows the CT value for N1 when the samples were processed fresh. And then also after a freeze-thaw cycle, and also after 5 days at room temperature or 3 days at 30 degrees Celsius. And on the right, what you see is these are all samples that were left at room temperature. In both of these graphs, dots that are joined by a dotted line represent the same sample. So the same sample, whether it was tested fresh, after a freeze-thaw, or at those different conditions. And on the graph on the right just shows that, you know, the single sample, one of the ones up towards the top, were tested fresh, but then also another 3 times. And what we really did is just, again, saw very, very stable detection of SARS-CoV-2 in our saliva samples without any preservatives, even up to 25 days just sitting there at room temperature. The next thing was to make sure that this was going to be sensitive without RNA extraction. So, we started developing this, it was back in April, really early May, when we were very, very, even back then, I was fearful of what false negatives could mean. And I didn't know what a low viral load could possibly mean. And, that risk of if someone had a very low viral load, having them out in the community, their risk to others. We also didn't know the future of testing back then. And, would we be having opportunities for frequent repeat testing, or was this only going to be a sort of a one-off test or a test at limited times? So we did want this test to be as sensitive as possible when we started designing it. So what we did throughout the validation is that we were comparing the samples that we were testing, having them tested side by side in the full RNA extraction method and in the method without RNA extraction, and to make sure that we were just preserving that sensitivity. And you'll see this is just some of our data as we were developing it, and we did have quite consistent detection without that RNA extraction. It also taught us, you'll see where there's one sample that's about at that 30 CT value in the extracted column, and its paired sample actually tested negative in Saliva Direct. That was also a really good learning curve for us, because that sample, we realized that one was actually also negative for RP. And that sample was really quite mucousy. It was more like a sputum sample rather than a good true saliva sample. And that helped us identify that so far the only sort of real inhibitory things that we've found for Saliva Direct are mucousy samples or even bloody samples. They can interfere with PCR detection. So that was good for us to identify, while overall being able to remove the RNA extraction step, which is the most expensive step, most time consuming, and we can maintain that sensitivity. We also did the same thing with moving from the singleplex to the multiplex setting. So originally we did try the multiplex rather than the dualplex, so having both N1 and N2 in there, as well as RP. What we just generally found is that even on our just normal clinical samples following RNA extraction, N2 just gave us a lot more noise in general as compared to N1. So just because of the greater discrepancy you would see sometimes with N2 in a sample, it could lead to more inconclusive results rather than telling us was this positive or negative. So for the sake of the simplicity for this method and the fact that N1 has been working very robustly for us, we just continued. We gave up on the idea of the multiplex with the N1 and N2 and decided just to use the N1 and the RP. We also just did a bit quick cross-reactivity for that. There's been a lot of work keeping, tabs on N1. So many labs all around the country are using this as a PCR target for SARS-CoV-2 detection. So there is a lot of monitoring of it for false positives or any sequence changes that could influence detection going forward. But we also had some saliva samples prior that were collected prior to the COVID-19 outbreak. So these were collected sort of December last year and also the year before. And so we just ran our assay on those pre-COVID saliva samples again, just to double check to make sure that N1 would come back negative, that we weren't having any other cross-reactivity with any other sort of upper respiratory tract microbiome. Now, so the thing, that also makes Saliva Direct very unique is the idea that at each of these different steps, we have validated reagents from different vendors. So, we've got various options for the proteinase K, various options for the PCR kits, and also for the PCR instrumentation. Our idea was to hope to help to avoid any supply chain issues. So just not to list a single company and have, a lot of demand go in there, or if one of these reagents fell under demand from other supply chains, that, there were going to be other options. we started out with the PCR instruments that we had available to us. Again, we wanted to make this so that people didn't have to go out and buy new PCR equipment, that hopefully they could use what they had available. So we have validated this for 3 so far. We're adding another 2 at the moment, and we're working with labs around the country to bridge on other PCR instrumentation. So a whole range of Quant Studio machines, both in 96 and 384 well format. So we're going to keep expanding this list. And as I sort of mentioned at the start, every time we make updates to this list, we are able to share those with the labs who are designated so that they can have all the most up-to-date information. Also going to those different suppliers just really helps to keep those prices down in terms of also competition between suppliers. So in total, the per sample cost just for the reagents is about $1.30 to $4.30 per sample. Realistically though, that's on list prices, with any discounts that people have with their standing relationships that they have with suppliers, or if they're ordering in bulk. In many cases, these reagents can come down to $1 per sample. We're keenly aware that this is not the only costs involved in testing, and that you have to have the facility to run this test in, the staff to do it, overheads, especially those in relation to your clear the clear setting of your lab. But we've had some labs already come back and commit $12 to $15 to us. We've had sellers that say that 20 to 35 is more in their range. Some say that they can't do it for less than about 50 to 60 per test. But either way, it means that we are seeing cheaper testing options come out compared to a lot of the tests out there, which do, some of them start at 65, some are more like $100, $150 per test. We did, of course, also do the limit of detection for for all of the combinations. So this is just just some of the graphs showing the lower limit of detection with some of the combinations that we did. So in these graphs, we were just changing the PCR kit that was being used to see where our LOD was. So we just tested down to 6 copies per microliter, and for some of our combinations, we hit 6 copies per microliter. Our least sensitive setup hits 12 copies per microliter, and some of our bridging work that we're doing at the moment, we're seeing it get down to 3 copies per microliter. Now, the FDA actually recently sent out a series of standards to people with EUAs just to help to try and standardize a lot of that LOD information that's out there at the moment, because there's been all sorts of sort of formatting errors, or, what have people actually been using to measure their LOD, were your standards even correct? So this has all been published by the FDA. You can find that online. And it was just really exciting to us to see that the LOD that we hit, which was 18,000 units per ml, was the same as the CDC's RNA extraction method. So the CDC's RNA extraction method, using the whole more expensive, time-consuming RNA extraction step, we hit the same limit of detection with our RNA extraction-free method. So that was also pretty reassuring to us as well. We did, of course, have to do our clinical validation. So first of all, what we had to do is to validate saliva as a sample type itself. So we had paired saliva and nasopharyngeal swabs. And we first of all just did this through the Thermo Fisher TaqPath COVID-19 kit. And we saw high concordance between nasopharyngeal swabs and saliva samples. We then tested the saliva in Saliva Direct. So the swabs are still processed in the TaqPath COVID-19 kit, and the saliva with Saliva Direct. And again, we saw a high concordance, 94% agreement, where 32 were positive in both. We did have an instance where saliva was negative in 2 positive swabs, but we also had Saliva Direct pick up 3 additional positives where the nasopharyngeal swab was negative. We also have been exploring Saliva Direct in terms of asymptomatic detection. So as there's been so many crazy things that have been happening for, I think, obviously for everyone over the last few months. One of ours was that the NBA emailed us one morning wanting to chat. They really had also identified that they were going to need to have frequent repeat testing to get the league back up and running. And they were really intrigued with what we were doing with Saliva, and knowing that, Saliva was definitely going to be a more desirable sample type going forward. So we entered into a research partnership with them, where we were able to piggyback off their logistics that they had set up sort of all around the country for their own testing. And we received close to 3,800 saliva samples from asymptomatic NBA players and staff. And we were able to compare these samples directly to they were having paired anterior nares and oral swabs that were being for their routine diagnostic testing, and that they were being processed by BioReference or Quest. And so we were able to compare the results that they were getting for detection with Saliva Direct. And we did actually see very high concordance between the detections that we found in saliva and the detections that they had in the nasal oral combined swabs. This actually only just got updated yesterday on our medRxiv preprint. And I just realized that I had submitted these slides before that data came out. So we have actually now published our data so far in the medRxiv preprint, but showing the exact numbers of those and what that concordance is. We saw a very high negative predictive agreement, and we had out of those roughly 3,800 samples, we did have 12 that tested invalid with invalid RP values. So like no RP came up, so there was some sort of inhibition in those samples. But at 0.3%, I think it worked out that was a very low invalid rate to have. And again, one of the problems with also nasopharyngeal swabs is that you can also be subject to false negativity due to the swab not being taken properly and not collecting enough material as well. So we have our updated website where labs can go to request designation. We're also going to be listing labs as they become designated and just have all sorts of information on this. We've very much been all for open science. So we actually first published our protocol online in, I think it was like June 16th. We've been sharing this with absolutely everyone and anyone just to try and get more testing options out there. So in summary, saliva, I think, is it's holding strong as an alternative sample type for SARS-CoV-2 detection. Being, it is a collection of the all oral fluid. So as you're allowing that saliva to pull into your mouth and sort of like picking up just, maybe even sometimes a little bit of like the nasal drip or mucociliary clearance, but also just like any maybe presence of virus in the salivary glands or even on the tongue. Previously, saliva has shown to have high concordance with nasopharyngeal swabs for the detection of other respiratory tract viruses, including other coronaviruses. One of those main benefits of saliva is that the healthcare workers are not required to collect saliva specimens, so it can reduce the risk of nosocomial transmission. It can eliminate the waiting time for specimen collection, so your results can be available sooner. And this can very much help screening large number of individuals, particularly if you're having frequent repeat testing, especially with less discomfort to patients and ultimately, again, that less risk to healthcare workers. So where to next? I mean, COVID-19, it's going to be with us for a while. We do need to continue having inexpensive, simple and scalable testing. We do need to see a shift in this thinking of traditional diagnostic testing, but rather tests that can be used for screening and ongoing surveillance. And this is like, one of the big topics of conversation at the moment about sensitivity, and that, these tests don't have to be as sensitive as possible right now, but it's more as long as they're sensitive enough to detect people. I mean, ideally, right before they become infectious would be best. But, as long as you can also identify infectious individuals and have them isolate to stop those chains of transmission. The benefits that we're seeing of saliva collection, especially if you're targeting N1 and not having to rely on that cold chain transport, could also prove to have greater benefits in low resource settings. We are going to continue to develop and validate saliva further, we do want to reduce diagnostic tests time and the costs involved. You know, we know that PCR is not ideal, but getting a test into the FDA, you know, we sort of had to sort of go with what was already more familiar, but you know, we are looking into, you know, pooling strategies, some of the either LAMP approaches, looking to help validate point of care in-home diagnostic platforms. We're of course also keenly aware of the flu season approaching. So with this being currently a dualplex assay, we've got room in there to start also targeting the likes of like flu A, flu B, RSV. And we would also like to explore antibody detection further with this as well. There's a great group at Johns Hopkins who have shown good antibody detection in saliva, and you know, the idea that you could take one single sample and test it both for present infection but also for past exposure can make saliva an even more valuable sample type. So I just leave on my slide of a, oops, sorry, too far. Just an acknowledgement slide, and just really highlighting that this has just been all of this, right from like getting all the samples, all the data management, enrolling, processing samples, the research that we've been doing has just been an incredible team effort with so many people involved, and it's just been so inspiring to see so many people come together and to really do what they can to help in this pandemic. So I'll leave it with that and happily take any questions. So should I just, I can see the Q&A, so I'm happy to go through those.
Thank you, Dr. Wiley. Thank you, Dr. Wiley. We will actually answer the Q&As at the end of the presentation.
Sorry.
Thank you. This was a great presentation, actually, and on a positive note, you know, for our struggle with COVID-19 in terms of reducing the risk to healthcare providers. Thank you for developing such an assay that can reduce the risk to us collecting these nasopharyngeal swabs. It's also now my pleasure to introduce our two speakers from Lebanon who are providing an update from the front lines. Actually, these two individuals are really from the front lines. One from the actual emergency department at the American University of Beirut, Dr. Evelyn Hitti, who chairs the Department of Emergency Medicine at AUB. She's also an associate professor of emergency medicine at the AUB School of Medicine. The other speaker is on the front lines of the national public health response, serving as the public health advisor to the Prime Minister for Health Affairs and Social Security. Dr. Petra Khouri, who's a clinical pharmacist, a PharmD by training, is really providing valuable input and leadership regarding the response in Lebanon that they will describe to you. This is very dear to my heart. As some of you may know, I'm Lebanese, and I'm an adjunct professor at the American University of Beirut. So with that, I'd like to ask Dr. Hitti to go ahead and get started.
Thank you, Dr. Kazi, and thank you, ACMT, for inviting us and for putting together this webinar series. Let me just take control. Just as a context, Lebanon is a small country that is on the southern border of Syria. Sorry, just. Southern border of Syria. I'm not controlling the, I'm not able to control it from.
Would you like us maybe to move the slides for you?
Yeah, because they're moving and I'm not clicking on anything. So if we can go back to the beginning, if possible.
Yes, I think Dea, can you?
I don't seem to have control over it. But I can talk while we get back to the beginning.
Yeah, and you can say, no, here we go. You can say, this is the beginning, I believe, and you can say next slide.
Okay. So what we're going to talk about quickly is just the national response to the COVID pandemic in Lebanon. given the low resource setting and the constraints of a low resource setting, with a focus on some of the things we felt were good measures, success measures at the beginning, and then also emerging challenges. So as many of you may know, Lebanon's a small country on the Mediterranean, and right before the COVID pandemic hit Lebanon, we were up against a political and economic crisis that basically toppled the government and sent the economy spiraling into a devaluating currency, increasing unemployment even prior to COVID. In addition to that, many of the constraints that we had facing the pandemic are constraints that many low middle income countries share, which is the high density of the population, multi-generational households. We have around 5 persons per household, and a healthcare sector that is highly privatized, and a public sector, leaving a public sector that's quite under-resourced. In addition to a supply chain that's predominantly foreign or dependent on foreign importation. Next slide. So to address those constraints, what the National Committee on COVID that was literally appointed a month prior to the first case, which was on February 21st, and was the first attempt at planning for a crisis at the scale that we were about to face, ended up following a very stringent containment approach to the pandemic. In the scoring of stringency, it was one of the highest worldwide. And what did that entail? It entailed, next slide. It entailed basically very early closures. When we were on February 21st, we saw the first case. Within 1 week, when we were still at 3 cases, the schools were closed. And this was a highly criticized initially measure. And then within a month, scaling up from schools up to public spaces, and then ultimately to border closure within a month. There was full lockdown, total border closure, trying to really flatten the curve. The other, I think, very successful measure that the government took in the initial phases was to give the health sector some opportunity to organize. They did not open up the care of and testing and care of COVID patients to all hospitals, but rather designated specific sites to receive patients, starting with a few public hospitals and then bringing in additional private hospitals as more time was gained. Next slide. This is our center. We were one of the first academic centers to start receiving COVID patients. And I have to say that the approach of designating, starting off with a public hospital that was doing all the testing and receiving, and this very heavy containment effort really gave us much needed time to prepare in terms of PPE, in terms of processes, in terms of staffing, and in terms of site. So we are one of the more resourced academic centers, and yet it was a struggle to become prepared to receive patients. So it was desperately needed time that we gained by the stringent containment effort. Next slide. So by country opening, which started around April, so first case February 21st, by April we were starting to gradually open, and Dr. Khouri is going to go over that opening strategy. We had at that point, because of all the country measures, had increased lab capacity, increased bed capacity, as well as vent capacity, and some factories had started producing local PPE as well as ventilators. Next slide, please. So July 1st is when we finally reopened the borders, when we were facing mounting economic pressures. And at that point, our growth rate had dropped from a peak of 4.6 down to less than 1. Our test positivities was 1.5, and we had around 251 cases per million persons. Close to what New Zealand, Singapore, and Taiwan had at the time, with a case fatality rate of about 1.9%. So far so good. And then facing mounting economic pressures, next slide. We opened the borders on July 1st, and the imported cases started coming in and driving local surges that then were compounded by the blast of August 4th. So I'm gonna give the floor over to Dr. Houri, who's gonna talk about the reopening strategy that we followed and some of the challenges we're currently facing, as well as some of the future steps trying to face the pandemic.
Dr. Houri, you can go ahead and unmute and take over the presentation.
Hello, can you hear me?
Yes,
Yes, we can. Go. Yes, we
but
can.
I do not have control over the presentation.
Correct. You can
Somebody
just
has
say
to.
next slide,
Yeah,
and we'll move it for
sure.
you.
Okay, thank you. So the reopening strategy was done in a way that we took into consideration the risk of transmission and the economical impact, and it was in a 5-phased way that we did not want to open very fast, and so every sector was evaluated. Next slide, please. And we took into consideration the 62 business sectors. They were invited to the table. 16 guidelines were customized and published. Many efforts were done, interministerial, and the private sector was a big partner with the reopening strategy. Next slide, please. However, all this came at a time where Lebanon, like Evelyn was just mentioned, is facing a big and huge economical crisis. And it's important to put this into perspective because during the lockdown, like all economies in the world, things got worse. And for a country that has a deficit, GDP to deficit, more than 150%, the unavailability of hard currency, the collapse of national currency ended up with lower household incomes and many layoffs and closing of businesses. And the latest figures on poverty rates are up to 55%. All of this limited the ability of the government to come up with any stimulus package to support COVID. And so the sectors were working on their own to try to survive, and everybody was in a survival mode. So as you can imagine, once the strategy of reopening started, things started to tumble. Next slide, please. So the key challenges that we faced once we opened, when it came to the healthcare sector, we had limited ability to sustain the sector financially. And the medical coverage of COVID patients surfaced. The government was not able to support the coverage of these cases. Insurances companies started refusing a pandemic coverage. And so the hospital started facing challenges of accepting COVID patients. And then on August 4th, unfortunately, the Beirut blast happened. This laid its heavy toll over the healthcare sector. 131 ICU beds were occupied by injured. 1,200 regular beds in the Beirut vicinity were occupied by inpatients, and 195 casualties. In total, 6,000 patients were treated in the healthcare sector within a period of 48 hours. In addition to this, 12 hospitals were destroyed, and so they became out of service. All of this, as you can imagine, ended up taking out from the ability of the healthcare sector to treat more COVID patients. The financial crisis laid its weight over the healthcare workers. Lots of demand worldwide with better offers. So we're facing a huge brain drain, immigration of talents, especially nurses. And our healthcare sector is suffering now from an outbreak. 2% of those tested on daily basis are healthcare workers. The contact tracing went down humongously because of financial reasons. The issue of managing overcrowded areas surfaced again. Lebanon has 2 million displaced and refugees. That's 20% of its population size. All of these are living in overcrowded, suboptimal health and social situation. The UN agencies had started supporting them and giving some support. However, in an outbreak and an epidemic, overcrowded areas brew virus spread. Next slide, please. The other issue that we started facing is the misinformation and disinformation. Initially, we had started with an aggressive communication campaign nationwide, but with the political instability and the Beirut blast, the COVID information dropped off the TV stations and the media, and it has stopped becoming an issue, top priority for the public. Behavioral change, that is an issue by itself that all countries are facing, where enforcing masks and social distancing. How about a country where individual priorities have shifted? COVID is no longer on their radar. Everybody is seeking to make ends meet. And so they're no longer worrying about considerations that a regular and a routine individual would worry about. They're not worrying about dying from COVID, but rather from famine. So their priorities have changed. Compliance with sectors. The government agencies and law enforcement had pulled out from enforcing any measures related to COVID due to the other instability issues and security reasons. The blast in Beirut and other, and we've recently had some terrorism activity in some urban areas. So many things came along with the COVID crisis that ended up where we stand today, which is a full-blown community transmission situation. That the routine measures that any country would resort to, which is a lockdown, a full lockdown, is no longer an option at the table. We are now looking into doing a color-coded map launched yesterday, where we will start closing down on the highest risk zones to massively test them and try to probably support them for a few days in order to stop the spread as much as we can. Thank you.
Great. Well, thank you very much for three excellent presentations. I'd like to turn the moderation over now to Dr. Robert Middleberg, who will help out with the Q&A on the questions from the first presentation, and then Dr. Kazi will help out with the Q&A for the second presentation. Dr. Middleberg.
Thank you, Dr. Wax. Dr. Wiley, I want to thank you for a wonderful presentation. For those of us who live in the lab industry, we know and recognize that anytime one can create a non-invasive test, it represents a giant leap forward, not only in testing, but getting individuals to actually get tested, which is always a problem. So I congratulate you and your colleagues at Yale for this powerful tool that is now in the COVID arsenal.
Thank you.
You're quite welcome. And a number of questions have come in, and some of them are a little bit repetitive to your presentation, but I think it's worth driving home some of the points if that's okay with you. But one of the first questions, I think it's a good question to get everybody on a ground level, is, can you clarify the distinction between N1, N2, and RP?
So N1 and R2 are just different regions of the virus RNA. So that is what you're targeting to see if virus is present in there. And RP is actually the human RNase P gene. And what you're detecting with the RP is just making sure that your sample is of high enough quality, or that everything has gone correctly with the test, just to make sure that, if you were seeing a negative based on that, you would know something had happened to the test itself, and that could give you a false negative.
Very good. A few questions around, and you addressed it somewhat in the presentation, but turnaround time in relation not only just to getting the saliva test done, but in relation to NP samples.
Yes, that's a good question. This is more efficient. So as I said, whether you were testing this was developed from the same method being used for the NP sample, so the same RNA extraction and qPCR testing method, but just now simply with saliva. Removing that RNA extraction does make it more efficient. We can turn around in our lab about 92 samples in, if if it's one person and they're just dedicated to do it, about 3 hours. Obviously, though, different labs will have different workflows, receiving different numbers of samples. There's no reason, though, that these results shouldn't be available within 24 hours, if not same day. I think the big thing, though, is what we're trying to do is that by getting other labs up and running, we're hoping that it means that more, there's so many labs who we're in communication with who weren't doing testing otherwise. So they're adding new tests to their communities. And if you can get now a test that can be done at your local community rather than shipping it off to, a reference lab across the country, and there's more sort of testing spaces available, this should help take that pressure off and help to bring those return times down and hopefully get results within 24 hours, which is what we all need to be to take action on those results.
That's fantastic timing. It really is, compared to what we heard early on and some of the things you hear about in the news. I think that's fantastic. So a couple questions. Can the saliva sample be collected in the field and transported to the lab? And also for physicians who are in private practice, are they able to collect samples? And if so, how do they go about doing that?
Yep. So, they can be collected in the field. They can be collected by physicians. You just need to be obviously working with a lab who are able to perform those tests for you.
Very good. You addressed a little bit about your development potentially of a point of care device. Can you give us a little more information about how far along maybe that is?
Yeah, so we're not, we're sort of just helping work with others. There's so many people have just stopped absolutely everything and given their all into all of this response. So there are so many people out there at the moment who are working to find solutions. So, I wouldn't be surprised if, we've already seen even in the last week or so, more and more mention of point of care tests coming out. These are only going to expand in number, I think, over the coming months. So, yeah.
Great. So a question I thought of is, with this development, what would be the argument for anyone wanting to do NP testing?
I think the only one that it's probably better suited for, the NP sample, is for your severely ill COVID-19 patients, or people who just for some other reason could maybe not produce a saliva sample. The severely ill COVID-19 inpatients, which we found is that often their samples, indeed, they were more mucousy, they were thicker, they were bloody even, and that blood and mucus can interfere with the test itself. So, in those settings, that would be, preferred to take a nasopharyngeal swab than to do the saliva testing.
Okay, so there was a question posed. Is there a way to get around or to try to prevent the mucousy samples or the bloody samples, or is that really out of control of the collector?
No, so what we're really trying to be advocate, what we are advocating for, is that we do have a very robust protocol for saliva collection. It's very important those who are either following the directions to give a sample, or if someone's giving instructions, just to be really sure that you're just giving a normal, true saliva sample. So if you're thinking about what's in your mouth at the moment, swallow everything out, and now just wait and allow that saliva just to naturally flow back into the mouth. You don't want to be coughing anything up. You don't want to be sniffing anything back. And as long as you're sort of highlighting those facts, that it is really just that really normal saliva that, it might take you to think about some food, something sour, even talking about saliva, but it's just that very normal saliva that should be tested and can make it a lot more easier to work in the lab compared to sort of more mucousy samples.
Okay. And just to reiterate, this test has received an EUA from the FDA at this point.
Yes.
That's great. Really great. I guess the last question I have is, oftentimes there are questions about reimbursement, and maybe this is not a question that you know about, but maybe you do. I'm going to presume that this test, the saliva test, has reached the same kind of reimbursement through Medicare and insurance companies. I know you spoke about ultimately the cost of the test that some companies are saying it costs them to run, but has the test been approved by Medicare and insurance companies for reimbursement?
I'm not sure. I haven't been working with any of those groups actually, but I mean, obviously these are labs who have been running these tests. You know, there's some of them quite big labs who will be running Saliva Direct. So I'm sure there must be something in place there for them to be getting reimbursements for that.
Okay. That's a summary of the main questions that were posed. And I, again, want to thank you very much, not only for your time, but for working so hard on this development. It really is, in my mind, a giant leap forward. And again, I congratulate you and your colleagues.
Thank you.
Dr. Wax, did you have any additional questions, or should I proceed with some questions to Dr. Hetti and Khouri?
I think two additional late questions regarding the lab first, and then you can proceed to the second two speakers. Well, one of them is, and this may have already been addressed, but in terms of finding a lab that utilizes this saliva test, what would be your first recommendation?
To first of all, just check our website. We will be updating that list of labs who we have designated as they go live. And then otherwise, if you are just aware of any high complexity CLIA labs in your area, you can also strongly urge them to get in touch with us and to sort of set up testing more locally as well.
Okay, great, thank you. And then the last question for now is, kind of a more generic question about the positivity of the PCR test, which is, how long does it stay positive? So in terms of someone who's, come down with COVID-19 and is recovered potentially, how long may it remain positive for after the recovery?
So like the swabs, this can also vary. So, I mean, this is a sensitive test. It is sensitive qPCR testing, so you can detect low levels of virus RNA. But of course, you run into the same issues that, I think a lot of people are discussing at the moment, that you can detect virus that is continuing to shed after infection. So in those cases, it's best to, follow the CDC's guidelines, which I believe is that, after about, I think it's about 10 or 14 days after symptom onset, then, you're sort of safe to sort of leave isolation or return to work, because your viral load should be then low enough again, even if you are still detecting that virus RNA. Okay, and the correlate in terms of how early on in the infection during the incubation period may it be detectable? Is it comparable to the NP test? Yeah, it's comparable. So of course, generally you can start with PCR testing and Saliva Direct included. You can start detecting individuals anywhere from 2 to 4 days before symptom onset. That does sort of depend on the person's infection, which does mean that, if you have had exposure, they do say that, your symptoms can show up to 14 days after exposure. So if you've been in contact with a positive individual yesterday, there's probably not much point in rushing out and getting tested only tomorrow. Go back, have a couple of tests just to make sure that if you do have any virus present, it is going to be detected during that 14-day window. Okay, great. Well, thank you very much. Okay, Dr. Kazi, for some remaining questions about Lebanon.
Yes, absolutely. Thank you, Dr. Wax. I have a few questions. Some are actually more from the emergency department standpoint for Dr. Hetti, so I'll start with those. But then I have a few for Dr. Khouri. So Dr. Hetti, you mentioned at the end that the case fatality rate was still close to 1%, despite all the surge. Is this, can you explain that? Is this a less, virulent virus?
I think what we're seeing is still the success of the initial strategy in terms of ramping up capacity. And in the overall scale of things, I mean, keeping in mind, we're still in the maybe 30,000 to 40,000 cases nationally. So we're still able to absorb the current number of cases. I think the challenge is just with the surge, the ability of continuing to ramp up bed availability and critical care capacity to meet what's ahead. And what all countries are facing, and especially in a place like Lebanon, where there is so much political turmoil and resource constraints, how sustaining even initially successful measures, I think, is the key challenge we're all being faced with. So I really think it's matching the capacity to the numbers, and we're at the brink of overwhelming, I think, what we prepared in the initial phases.
Certainly, that's very challenging. What about your colleagues? And you're a chairperson of the large department, and can you tell us a little bit more about the healthcare providers, situation and struggle?
I think the main struggle that the health sector in general is seeing is not one just of bed capacity and ventilators anymore, but we have a very mobile health sector. And what we're starting to see is a lot of emigration of nursing and physician staff out of the country. And I think this is the emerging threat right now in terms of being able to care for COVID patients. So in general, prior to this crisis and prior to the economic crisis, I would say that Lebanon's healthcare system, both in terms of expertise and capacity, is quite good, and our number of physicians per capita is quite high compared to global levels. But that's something that soon I think will become a bigger problem as we move forward.
Actually, a question just came in that brings Dr. Wiley back with you, Dr. Hetti, and Dr. Khouri. Actually, one of our viewers says, would it be possible for the first speaker to work with the two speakers from Lebanon to set up a saliva assay in Lebanon? Well, I guess let's ask Evelyn and Petra first, and then we can go back to Dr. Wiley and see how would we maybe use a test like that in Lebanon, considering the resource issue we have in Lebanon.
Can I answer or Evelyn? Okay. Yeah. So I think given that this test is from the presentation is on the cheaper side than the PCR, the routine PCR testing, and in a country that every penny counts, it would make a big difference when we're doing massive testing. But it also depends on the accuracy, as the challenges that were mentioned earlier.
Now, Dr. Wiley, can you comment on exporting your technology outside the US? Is that possible?
It certainly is. As I said, like, we're all about open science, getting testing out there. So indeed, we made our protocol publicly available months ago now, and we are openly sharing it and recommending it to anyone who is interested. The EUA does only apply to the US, so that doesn't stop labs anywhere else from using it. It's more just that, indeed, talking to local testing, making sure that it's everything's all the requirements are fulfilled when setting it up in your country locally.
Thank you. Then I go back to Dr. Khouri here. Dr. Khouri, one of the viewers asked a question about how can you describe your challenges as a public health advisor? As a governmental public health advisor, what are unique challenges in that role compared to being a public health professional or a healthcare provider in Lebanon?
I mean, I think every public health official in these days with COVID crisis, they're facing the same challenges everywhere in the world, except that in Lebanon, it's a triple stress because of the economical and the financial crisis that is happening. These are the most challenges. Is we're having more than one crisis at the same time: COVID, financial, security issues. Everything is falling apart at the same time.
Is there a silver lining? Is there any positive, incident or event in the horizon? Are there any ways the international community can help Lebanon? Somebody asked that question. What can they do to help Lebanon?
A lot of effort after the Beirut blast. Many NGOs, non-governmental agencies have come in place. Lots of donations came in to the government. But most of them were related to trauma and not to COVID. in terms of healthcare. And so the challenge that we're facing now is that we're not in a war. So the trauma phase that we faced after the explosion, we're beyond it. And we're calling to everybody that we do not need AIDS with that respect. We're looking more into COVID AIDS.
Hopefully that aid will come in. I think, certainly Lebanon needs it. And I'm sure other countries also around the world are suffering with the same economic impact. From your contact tracing data, anything interesting that you can share regarding the locations of highest risk? Have you looked at that? Protests, prisons, social events?
So, I mean, like I mentioned, the overcrowded areas have been a big challenge. Prisons, we've had 2 prisons outbreaks in the last 2 weeks. The prisons, they're overcrowded more than their capacity by 2 times. So the prisoners, they're looking for some leeway to get out. So they're infecting each other's instead of applying measures the way they should. So that by itself is a challenge that we're facing. Nursing homes, we've had a couple of nursing home outbreaks. And the protests, it's interesting enough that when the protest broke out in June prior to the blast, actually in July, we did see some surge. However, with the August 4 blast, everything came on top of each other. So we couldn't make anything out of the data that was coming in because we weren't sure, was this related to the blast and the destroyed houses? We have more than 300,000 people displaced. So these people are going back and forth fixing their houses, more than 85,000 houses destroyed. So lots of movements, no measures being applied, of course, because everybody's trying to get their houses fixed before the winter. So I'm not sure if it is related to the protests or it's the Beirut blast. I mean, you can imagine treating 6,000 people in 48 hours. Lots of measures have been violated just to save lives.
I know, and I hope, Lebanon will continue to be alert for other infections, transmissible infections that could occur. And, if there's any relaxation of vaccination campaigns, especially in children, we can see resurgence of diseases that have been controlled in Lebanon for many years. Thank you so much for your presentation, Dr. Khoury, Dr. Hetti. I'll turn it back over to Dr. Wax for any last questions and closing comments.
And I'd just like to, again, thank the presenters today and thank Dr. Middleberg for moderating the Q&A and Dr. Kazi, very much appreciated. Next slide. So as mentioned at the outset, this webinar has been recorded. It will be posted to our website. We appreciate any feedback as we move forward with our webinar series. Questions can be emailed to us at webinars@acmt.net. Next slide. We'll be continuing the webinar series in October. We're going to be moving to an every other week periodicity for this webinar series from October on out. We plan to maintain this webinar series into 2021 and bring to the group the most cutting edge speakers and timely topics that we can identify. So we look forward to working closely with everyone in the coming months. Clearly COVID-19 is not going away, and we all need to continue to prepare ourselves for the challenges that lie ahead. Next slide. Finally, we have an updated prospectus on what we've previously provided. This can be pulled down on our website, and will provide access to all the previous webinars as well as upcoming webinars. At this point, I'd like to thank everyone again and have a good day.